So I'm going to take the position that the relapses do matter, and the question is, when do they matter? And in 2017, as we are having this conversation or debate, I think we have to remember that the definition of relapse had been pretty much pre-MRI era. And in 5 years' time, I think increasingly we would be using the word activity rather than relapses. And equally, this is something I want to flag up at this stage, which is what actually we mean by disability in MS. Is it what we define as EDSS, where patient is unable to walk without support, score of 6, or bedbound 8 or 10, the patient is dead? Are these the essential hard points of disability we want to explore in multiple sclerosis in next generation? I pretty much doubt it. So let me start off by saying that this is a common picture which we have seen throughout this afternoon, and I would argue that if you're starting to treat at this point for relapsing remitting disease, which is probably 10 years down the line, that is going to make much of a difference in terms of disability progression or outcome. However, there is a reasonable body of evidence that if patients who experience high-frequency early relapses in symptomatic disease, they tend to get worse prognosis, and I'm talking typically of relapsing remitting MS. So this was Professor Venishankar. Yes, it was the Middlesex cohort. It's pre-treatment cohort, and I have just tweaked the data, which basically shows that even in 1980s, patients who had fewer attacks in the first 2 years tended to do much better than those who had more than 5 attacks in the first 2 years. So it's not a surprise that, the patients with more frequent relapses in early years did worse. And this is Antonio Scialfari's paper, which I think our host has kindly gone over, but I'm not going to talk too much other than saying that it was quite clear from this analysis that patients with high-frequency relapse in the first 2 years did a lot worse. So the emphasis is clearly on early frequency of relapses in symptomatic patients. Now, in terms of the treatment with disease-modifying therapy, in general terms, they were developed to reduce relapses. Of course, that has changed a little bit with newer drugs. And the primary endpoints that were explored were reduced relapse rate and MRI changes of T2 lesion load and enhancing T1 lesion. With newer drugs, admittedly, we have very short outcome in terms of effect on disability limitation. Now, why the MRI parameters came was based on this work from David Miller's group, published in New England Journal in 2002, which showed quite clearly that there is a relationship with MRI activity and disability progression. And 10 years later, the same group, Professor Miller's group, confirmed the findings with a 20-year follow-up that there is a reasonable correlation of T2 MRI lesions and disability, and hence the argument in favor of using disease-modifying therapy. And I mentioned about the newer drugs, so this is the Freedom study, again short-term improvement in disability, and that's the alemtuzumab trial confirming benefit in terms of short-term disability reduction. Now, in general terms, and I'm being very, very broad here, the disability in multiple sclerosis is effectively due to progressive brain and spinal cord atrophy. And the newer high-efficacy choices seem to suggest that there is some benefit of this therapy on brain atrophy rate. So what I'm moving on is what actually is the target of treatment effect. Spinal cord atrophy equally is shown to correlate with impaired walking and disability progression. It's a bit difficult to measure with conventional scans, although Professor Miller assured me last time that that's being looked into with the newest trials that are being undertaken. So this is the paper which Maria Sormani wrote, and I am sure most members of the audience will be aware of the finding that treatment effect on brain atrophy correlates with treatment effect on disability in multiple sclerosis. And she demonstrated it further by doing these graphs, which, as you can see, looked at the effect of treatment on brain volume, on lesion as well as brain volume. And the effect of brain volume loss was independent of effect of lesions on disability, and that establishes the view that there is a difference between relapse and disability progression. However, the treatment, and at least the high efficacy drugs, seem to target that process as well. So that brings us to the next part of the talk, that what is brain volume and how important it is. And I think in terms of disability progression, brain volume loss is a very important biomarker and is also an important outcome measure for neuroprotection or treatment efficacy in MS trials. And that's the normal rate of brain volume loss. Sadly, we are all losing our brain volume at least around 0.1 to 0.3% rate. In early stage MS, the loss of volume is around 0.7, and in more frequently relapsing patients and in later stages, it accelerates, and obviously you are more likely to be able to contain an early stage MS in terms of volume loss rather than late stage. And that is the final point here, that relapses cause brain volume loss, and hence relapses do matter in terms of progressive brain atrophy, and translate that, which means in long-term disability. Now you will say, what's the proof? So the best proof came from the follow-up of patients with clinically isolated syndrome who eventually converted to multiple sclerosis. So during the first year after CIS, a patient who developed a second attack, they get much bigger drop in their brain volume, and you could actually show it even going back to what we now define as radiological isolated syndrome, that those patients who tend to drop their volume, they are at higher risk of conversion to CIS or RRMS. Therefore, when we are talking about therapy, is the prevention of brain volume loss, or BVL, not a great abbreviation, which should be the actual focus. And not only BVL is important in terms of the overall disability progression in motor score, this is also fundamentally well correlated with fatigue and cognitive impairment. And many patients with MS, as we shall see probably towards the end, they find it difficult to continue with their work, not because they are physically disabled or with a high EDSS score of 6, but they have severe fatigue or cognitive impairment, and we should start regarding these aspects of MS as disabling, rather than just equate motor impairment as the only measure of progressive disability. And again, this shows that higher brain volume change from baseline to 2 years would actually correlate with long-term EDSS at the end of 8 years. So you can see that in the first 2 years, you get a predictive picture of patients who are likely to progress to higher EDSS. And if you don't treat patients in year 1, either because they don't meet the criteria or whatever, they tend to lose brain volume quite early on. So if you put the pictures together, it sort of suggests that BVL loss is quite early and accelerated in patients who are more prone to high-frequency relapses. And this is clearly a better marker of physical disability, not only in the short term, i.e. at the point of conversion from CIS to MS, but in the longer term, 8 or 10 years down the line, if they continue to lose their brain volume. So patients without disability progression had less brain volume loss per year than patients with disability progression. And you can look at the interquartile range over there. Now I have 5 minutes, so I'm going to rush you through a patient, and a single case may not mean anything, but I'm just going to show you a young patient presenting with a relapse, and I'm not going to define the changes, which you will pick up. This was treated with plasma exchange, steroids, of course, followed by what would be termed as induction therapy. And this is month 9, and you can see the degree of brain volume loss. Of course, you know, the areas of hyperintense signal change in brainstem has disappeared, but look at the level of brain atrophy that occurs within 9 months. Just showing that people, and he is very functionally impaired despite high efficacy drug treatment. And this is just an example that how important is the correlation of brain volume loss in terms of predicting or forecasting long-term disability. And there is no way you could target that without using high efficacy therapy, of course in appropriate patients with right diagnosis and everything else. I think we heard again this afternoon quite often about the dissociation of relapse and progression, and Confraview's paper in 2000 clearly pointed out an amnesic process once the DSS threshold goes beyond 4.5, and Professor Eden's paper also showed that beyond a cutoff point for EDSS, there is probably not much of biological inflammation that you can contain. So the message from here is that if you keep waiting for patients to accumulate relapses, progress towards 3.5, 4.5 EDSS score, and then begin treating the patient, you are not probably going to get any far in terms of reducing long-term disability. On the other hand, if you are targeting individuals under 4 and treating them early, you have the best chance of reducing their long-term disability. And that kind of study has never been designed to address the core question that whether early treatment can reduce long-term disability. And this is the final picture I want to show you, and this is from a paper published 10 years back. But just look where 50% patients actually stop working. Their EDSS score is 3.5. So they are able to walk without any problem because your first walking impairment is EDSS 4. So before they actually reach that point, half of them stop working, and that's because of their fatigue and cognitive issues. And those factors are not taken into account when you're trying to look at relapse rate in the conventional terms and the treatment efficacy. So to round up, early, frequent, and untreated relapses can cause disability progression, and this disability is not disability of movements. It could impact on their cognitive function, their level of fatigue, and maybe even mood and their ability to perform as an individual in the society. So the test of efficacy of disease-modifying therapy, at least in next 10 years, is not just going to be relapse rate reduction or MRI changes, but also preventing brain volume loss and maintaining disability status either at the same or at an improved level. And I personally feel that patients with brainstem and spinal cord activity have a very high risk of progressive disability because they don't have much compensatory function left in those areas because of the volume issue, and they should be started on high efficacy therapy without much delay, and they should probably benefit from, well, at least annual, if not 6-monthly MRI to know if they are responders to treatment. So I'm going to conclude here, Chris, and maybe you would like to come.